Good evening. Good evening.
Good evening. How are you
Good.
doing?
Always good on our end.
Always.
Always good, and some days great.
I love that attitude. Yep. We appreciate everyone that's here with us this evening for season 4, episode 21 of Doc Talks with Dr. Forrest Tennant and friends. Doc, I know you have a great show ahead of us as always, and so it's all yours. Please take it away. Thanks so much.
Welcome, everyone, to this Christmas season show. We've got some special things here tonight to talk about, some very positive things. So I thought I'd get the negative part out of our way first. This week, I was shocked to receive this article. Okay. And our good friend Pat Anson, who has Pain News Network, and incidentally, if you don't subscribe to that or don't watch it regularly, you should. But an institute known as the Lowen Institute has done a study and found that an unnecessary back surgery is being done by our surgeons in hospitals in this country every 8 minutes. They claim that over 200,000 unnecessary back surgeries are being done every year. Now, the reason why this is not only applicable to us, and I realize that a lot of people on this show have had back surgeries, and my guess is a lot of you have had unnecessary back surgeries. This is a damning article. It's the first one that sort of proves something we've all believed and wondered about. Now, some years ago, as most of you know, I got into treating adhesive arachnoiditis because it became the number one reason to need high-dose opioids for severe chronic pain. And so we started to study this, and initially we wondered why it seemed to be increasing in the population. The first candidate was excess epidural injections. Surgery was sort of a consideration, but we're not certain. Now, I have here with me one of my first books on adhesive arachnoiditis called Clinical Diagnosis and Treatment of Adhesive Arachnoiditis. And I have in the book one of our first series of patients of 60, and here's a table of 80 documented MRI adhesive arachnoiditis patients. I'm going to give you some of our statistics, okay? Now, first off, of these 80 people, 43, slightly over half, had already had back surgeries. Now, keep that in mind. 43 patients. These 43 patients had had a total of 91 back surgeries. Okay. Now, 69 of these patients, 70 out of 80, had had epidurals, and believe it or not, of these 70 people, they had had a total of 236 epidurals. Now, when I first published this, and this was 5 years back, I wasn't certain. But you simply can't sit there and have 2, 3, 5 epidurals and not get adhesive arachnoiditis. You simply have that disc operated on, you're probably going to get adhesive arachnoiditis. Now, we used to call this failed back surgery syndrome. Now, today, with this new sophisticated contrast MRIs, I've looked at now probably 2,000 people who have the symptoms of arachnoiditis. And we can see today on these contrast MRIs, you can see where the caudal nerve roots are inflamed, whether they've developed adhesions. We now know that the Epstein-Barr virus will probably invade right away after these surgeries. In other words, this is a tragic national problem. There's also been the theory expounded. I'm going to ask Dr. Ibsen, and I've already asked him to comment on this, and Mark may want to comment now or later. It's been suggested that, yeah, maybe it's the cartel that's behind trying to suppress opioids. Maybe it's the pharmaceutical industries trying to sell their new drugs. But I've already heard it many times that a lot of surgeons and hospitals and insurance plans don't want opioids used for good pain relief given. They want surgeries. I hate to say it, but we might as well say it. It's starting to look like some insurance plans, some hospitals, some surgeons look at a patient, not as a patient and as someone needs help, but as an economic unit walking in the door. Now, this is a tragedy in America, and I ask everybody out there, I don't want to throw any arrows. I'll let you decide whether an arrow has been thrown. I'll let you decide, and the public needs to decide what is going on with this, okay? I mean, this institute who did this study, let's say they're half off. That's still 1 every 16 minutes, okay? In other words, that's if they're 50% wrong. This needs to be looked at, talked about it, and also it needs to be thrown into the till that maybe there's a lot of people out there didn't want opioids used. Now let me throw another thing at you. Doctors like myself and those who treat severe intractable pain, we're kind of a mop-up crew. Okay? We're sort of mopping up after all of this catastrophe. Now, Mark, I see you there. Chime in. I know I've asked you to talk about this. Go ahead. Give me your first thoughts, and then your second thoughts on not only what you think where we're at, also what should people do about this.
I'm not sure I can have more than one at a time.
Yeah. Right. Well, try a half.
Okay, so I don't know if anybody remembers, but in 2014, there was a lot of stuff talking about how in America we use 97% of the hydrocodone on the planet. And they never mentioned that in America we use hydrocodone and the rest of the world uses diacetylcodeine. And so that was a skewed amount. And it was sort of like implying that, oh, we're just this opioid dependent nation and we're weak and blah, blah, blah. Those quotes don't happen anymore. I don't know if you haven't noticed, but I haven't heard that quote in a long time. What I want to offer is that we not only produce hydrocodone and use a lot of it, we lead the world in surgical procedures. And what this is telling us is, well, I worked in Zanskar, and I was seeing patients at the Dalai Lama's hospital. I saw one person with a scar on their back, and that person had scoliosis. They had to move to Delhi for a year to get their scoliosis surgery, and they were in chronic pain, untreated, no opiates. But everybody else hurt and ached, but never had a surgical procedure because in poverty-stricken areas, you die from your trauma. You don't, so you don't have a consequence that you have to clean up later because there's no one to do the surgeries and you just die from your fall or whatever happens from going to bed. So my theory is that, and what I'd like to see linked together, maybe in a policy way, would be that there should be some sort of no-fault insurance or some sort of guarantee that's been implied and no longer can be held, is that if we start carving on you, we're going to take care of you either way. Either you get a good surgical result or we'll treat your pain. And instead of having it be a crapshoot that, okay, well, somewhere between 3 and 5 and 10% of you are going to be in agony the rest of your life. The others of you are going to be able to move on. Thank you very much. And not have any complications. And so I think that you're onto something. And this is going to be a tsunami if it's not buried, ignored, or debunked in some way. So yeah, we're the cleanup crew, and instead of putting us in jail, somebody ought to start thanking us.
Yeah, right. Maybe, yeah. Let's get a T-shirt with a garbage can on it or something like this. Yeah, and a broom.
Yeah. I'm at your service. I'm here to mop up.
Yeah. One wonders about all the doctors who have gone to prison, been charged, disciplined, one thing or another. Well, how many of those patients they were treating were victims of unnecessary spine surgery? You can only
Over
wonder.
50%.
At least 50%. Absolutely. Okay. Well, Mark, I'm gonna, if you want to think and come back and talk about this, because I do want to talk to you more about how things went yesterday, which I understand was terrific and people loved it. So I want to come back and hear about more about yesterday. But let me move on a couple of things here today real quick. One thing about education I want to talk to everybody about, and that is a concept as opposed to a specific disease or a specific drug. I want to talk about the concept of low dose intermittent therapeutics. Okay. Now, why am I onto this? Today, if you have chronic severe pain, regardless of its cause, you're going to have to plan to be on medications all of your life. And the problem we have is that we don't have a large menu. We have a relatively small menu of drugs that work. And consequently, you can't just go out there and start taking some of these drugs, because if you do, you're going to get tolerant to them and they're not going to work anymore. And you may also get complications. Now, this has come up primarily because physicians everywhere have been told not to use corticosteroids because they have complications. It's been published that the other drug we gotta have, frankly, in my opinion, you can't do without it, is ketorolac, or the drug Toradol. Why? Now, these two drugs, the methylprednisolone or the dexamethasone, those are the corticosteroids that are the most potent because they are the two that cross your blood-brain barrier and have receptors in the brain and spinal cord. And that's why when you have a chronic pain problem, you're going to develop central pain with your glial cells, even if your main cause of your pain may be your hips or your foot. So we've got to have drugs that get across the blood-brain barrier and get into the spinal fluid and will attach to certain receptors in the brain and spinal cord. Now, these two corticosteroids and ketorolac do that. Now, we don't have a third. Okay? We got a lot of antidepressants out there, and there's only a couple that may cross the blood-brain barrier and help you out. One is diclofenac. It's not near as good as ketorolac, but it's something. The old drug indomethacin sometimes seem to work, but your ordinary anti-inflammatories like Motrin, Alphon, Celebrex, they're not going to cross the blood-brain barrier and get the job done. Now, it turns out these drugs that cross the blood-brain barrier and get into the spinal fluid, you can get tolerant to them and they've got side effects. You can't take them every day, okay? Now, what do we mean by intermittent use? That's a term that I want everybody who's got chronic pain to really understand. Intermittent means no more than 4 days a week of dosing. Okay, and that means you skip days. You gotta skip days. You can't take it every day. If you take methylprednisolone every day or ketorolac every day, if you don't get side effects, you're gonna get tolerant, and pretty soon you don't have a backup drug, okay? So those two drugs are good. Now, let me give you some examples of what I'm getting at. I've had some luck in trying to educate physicians. I know you don't like corticosteroids. Look, doc, what about 1 day a week? How about methylprednisolone at 2 or 4 milligrams just on Mondays? What about 10 milligrams of ketorolac maybe on Wednesdays? Maybe if you're even more scared of that, what about 1 day a month? 2 days a month? In other words, I just want to make it clear, if you've got adhesive arachnoiditis, if you're found to have Epstein-Barr reactivation and autoimmunity, you're going to need a corticosteroid and you're going to need ketorolac. Now, we just don't have an anti-inflammatory to replace ketorolac, and we don't have any real good corticosteroids to replace methylprednisolone or dexamethasone. So if you get side effects to one of those two drugs, or you get tolerant to them, you're up creek without a paddle. Okay? So low dose intermittent use. Now, I've got some other drugs that I want to pass on to you about using them intermittently at low dosages. Okay, now I'm going to give you some others that come under that category. One is some of the hormones. For example, nandrolone. Now I know it's not used very often, but it ought to be. And the reason it's not is everybody's afraid of it. Nandrolone is an anabolic steroid. The other one that we really like, if we can get it, is human chorionic gonadotrophin, HCG. And one that should be used a lot, but hardly ever used, is medroxyprogesterone. Now, these are prescription, potent growth hormones. They restore damaged tissue. So if you've got Epstein-Barr virus, you've got adhesive arachnoiditis, you've got a CRPS, you've got abdominal adhesion, small fiber neuropathies, whatever you have, you're going to need these potent hormones to try to restore or regrow those damaged tissues. Now, every one of those hormones, if you take them every day of the week, within 1 month, you're going to be so tolerant, they're not going to work. So you've got to keep those dosages down to 2 to 3, 4 days a week at max. So those hormones, you want to stay down low. Now, let me give you another one that's going to surprise you. The peptides. Okay. I hear all the time, oh my gosh, doctor, I was taking KPV and it was working good for a month. Now it doesn't work anymore. Well, how often were you taking it? Oh, I was taking it every day, sometimes twice a day. Wrong. If you were taking it over 3 times a week, plan on it not working after a month. Okay. Now, let me go on and talk a little bit about peptides for just a moment, because I've got some news about the peptides that I want to keep you updated on. Now, first off, the peptides. Some people, and I was hopeful too, that the peptides would replace corticosteroids. We were hopeful it would replace ketorolac, replace oxycodone, replace naltrexone. No. They're great add-ons. They're going to give you a boost in your program. They're going to help you relieve your pain, restore your tissues, keep your virus down, but they're not a substitute for these other treatments. Time has gone on long enough now that I don't want anybody to read anything, say anything, to think that they're going to get around the opioids. They're not going to get around ketorolac. You're not going to get around Medrol. But the peptides used correctly are a dynamite add-on option, increasing the effectiveness of your overall program. Now, 4 peptides have emerged out of about 60 on the market as being being effective for chronic pain patients. And these are the 4 that have come out to be, to look like to be effective. They're very popular, increasingly popular, and they keep their power as long as you use them, don't use them over 3 times a week. Okay? Now I'm going to read these 4 to you. BPC 157, that stands for body protection compound. KPV, which was kind of the first one, that's a chain of 3 amino acids, lysine, proline, and valine. ARA 290, that's called cimetidine. That's a dynamite nerve regenerator. And lastly, thymosin beta. That's a chain of 43 amino acids, and it's got a tremendous boost to your immune system, helps fight viruses, helps regrow tissues. So those 4, BPC 157, KPV, ARA 290, and thymosin beta 500. Personally, I'm very high on these products where they combine the BPC 157 and thymosin beta 500. Now, believe it or not, these peptides can be found as an injectable, nasal spray, tablet, under your tongue, or rub on skin. Okay, so these entrepreneurs have really come forward and really developed these different formulations. So you can kind of pick the favorite one you like. whether it's a nasal spray, out of the tongue, oral, or injectable. That said, injectable is probably the most consistent and the best. But a lot of people can't stand taking injections. I don't blame you. And nasal's awfully good. Now, a couple of other things about these. I get asked all the time, gee, Dr. Tennant, what's the best place to get my peptides? Where do I get them? Today, I went through my records and I found 10 different companies that sell the peptides. 10, okay? Now, I don't know which one's the best. I don't know which one's the cheapest. There's 10 of them out there that are making these 4 hormones, and I don't. If I knew of one that was superior, I wouldn't. But my guess is they're all kind of about the same. So pick the one that will match your pocketbook. Pick the one that will make your formulation, whether it's injectable or nasal or oral, that you like the best. In other words, you've got a lot of choices. They've become like vitamin C. A lot of different places you can buy them, and you should buy them according to whatever your pocketbook will cover. I don't know of any health plans yet that will cover the peptides. So it's out of pocket. And so if you can afford 1 or 2, do it. But anyway, that's where we stand on those. Another problem with the peptides is dosage. I don't know what the dosage is. Okay. And they don't label these things like a normal over-the-counter drug or prescription drug. So you're kind of on your own also when you use these things. Sometimes they'll give you some labeled instructions, but maybe you can ask a friend on the program here or on your Facebook group or somebody you know what they've had good luck with, or maybe just kind of take the lowest dose that they allow you to take and take it. If it's an oral capsule, start with 1 a day, maybe. Start low and then you can work up. But again, what I want to tell you is that these peptides are great on your program, but they are not a substitute for our other things like your pain relievers and your tissue restorers or your antiviral agents. They're not substitutes. One last thing about the peptides that people are trying. I don't have enough positive reports to recommend them yet, but GHK copper and desmorelin is another one that these are being tried. But as of yet, I don't have enough reports to recommend it. With that, let's see if we can bring our guest on.
Sure. Welcome, Katie, everyone.
Hi.
Welcome to
Good to
Doc
see you
Talk.
again, love. It was so
Yes.
nice speaking to you yesterday.
It was great.
I want to thank Dr. Tennant. I have literally a whole page of notes here with
Yeah,
what we're talking about because it actually applies to my situation. Irony is irony.
Yeah, good. Well, now, Katie, let's start at the beginning.
Yeah,
One of the
sure.
reasons why we're so anxious to have you is that I understand you're a paramedic, so you've got some
Yes.
medical background, and then you've got one of our terrible diseases, right?
More than one of them, but yes, I have complex.
Okay. Give us your laundry list of everything that's wrong with you.
Well, it actually starts from when I was born. I kind of wanted to set my goal and my intention in speaking out as a patient because I was kind of scared to for a long time, especially while I was working, because there's a lot of stigma that comes with being a chronic pain patient that works in healthcare. But there seems to be this common sort of theme impression people have of patients like us where, we got one prescription from a doctor after we had surgery or we broke a leg and all of a sudden we're addicted to opioids and we're on the streets. And that's not my story. And that's not the story of, I think, anyone that's here. And I kind of want to sort of reframe that narrative for people. My first head trauma was actually when I was 4 years old. You can't really see it well, but I got a big old scar there. And let's see here. My first back injury was when I was 10 years old. It was an accident in gym class. And then, my body over the years has had multiple injuries. I was in a fatal house fire when I was 15, where I had a loss of consciousness from falling down the stairs and a anoxic brain injury. I was in a head-on collision at 19. I did 22 years of direct patient care starting at age 17. And that, of course, anyone who's been a nurse or been working, taking care of patients, you know how hard that is on your body. And then it kind of culminated at the end of 2021. I was having laser therapy getting ready for my wedding. And I was laying on a table and they told me to lift my leg up so they could get under my leg. And I did. And the whole table flipped backwards and my whole body came down and all my body weight came on my head right here. So I actually have a healed depressed skull fracture right here. And that was what I call the big one. That was a brain injury that stayed with permanent ongoing disability. So if you look at my films, I have 2 discs out in my neck. I have something called double crush phenomenon. I have impingement in my radial and median nerve on my left hand here. I've got my C6 and C7 that are impinged. I've got problems in my mid back. I've got 3 discs out in my lower back. I've got radiculopathy that's really bad on my left leg, goes all the way down to my foot. My whole life, it turns out I've probably had Ehlers-Danlos syndrome. So I have joints that pop out that don't want to go back in anymore. Once they're hurt and they don't want to heal. And yeah, I just kind of have sort of the trifecta of things going on. Or not the trifecta. Most recently, I had COVID right before my wedding, and I started developing POTS symptoms after that. And then after I had COVID a year ago, I started developing gastroparesis symptoms as well as issues with my bladder, where it has a mind of its own.
Katie, let's stop right here because I want to, you brought up some points that I know I've been trying to make, Mark's been trying to make, and you're a poster child here on something. And that is, you started off with pains when you were 4 years old. And where were,
Yep, my first injury was 4 years old. Yep.
yeah, where were your pains at that age?
It was my head. I would have headaches and stuff after. What happened was I fell down the stairs and I hit a door jamb and I split my forehead open.
And
then
you were 4 years old at the time. And then
when
you
I
had
was
another
10,
accident.
I had a back injury at 10. I was tumbling in gym class. And
Okay.
then I had another injury again at 15 when I was in the fire.
Okay. Now, did anybody suggest you had any kind of a genetic or connective tissue or collagen disease when you were a child?
Never, not until this year has it been suggested to me. And it turns out my mother has Ehlers as well.
How old were you when you were diagnosed?
This year, 40. And I'm still actually waiting to see the rare diseases clinic to get the formal rubber stamp, but my other providers have already said that I have it.
So you were undiagnosed till middle age,
Correct.
right? Yeah, if you consider
Yes.
40 in the middle, okay.
I don't, but
You can either answer it now or you can answer it later. What do we do as a nation and as a medical profession to get families, doctors, nurses, schools to realize that when they get somebody under age 20 who's got all these painful issues, that you're looking at EDS or one of its sister diseases right down the throat. How do we do that? You have any ideas? How do we bring
I think
that
it's
kind
just
of
about
awareness?
education. I think 2 things come to mind when you say that. I think the first is a lot more parents are becoming educated. And so when they're seeing signs in their children of these things, they're speaking out and they're making their care team for their children listen. I think that's the first thing. And we are starting to see that. And I think the other thing, you can think what you want to about this or not, but I feel like a lot of these things that I've been diagnosed with are things that run in clusters in women, in female patients. You know, you're born with a uterus and you are more predisposed to some of these syndromes. They tend to run together. They call it a syndrome for a reason, right? And women's health care has not been a priority in this country, and frankly, still isn't a priority in this country. And I think making women's well-being a priority, more of a priority, I think that's part of the solution as well.
Yeah, in other words, it's the old saga old saw that women are weak and related to female problems, when in truth it's totally something different.
Exactly. And, and you look at clinical trials, they're all done on healthy 20-year-old college boys, medicinal trials, same thing. We're not testing out medications, different types of therapies. We're not doing that in patients that really need them. And so we still really have no idea what the solution is for a lot of patients like me, simply because the time and the effort isn't being put in to find it.
Now, let me go back to your own situation. Now, do you have children? Do you work? Tell us something more about yourself.
That's another story. I've actually dealt with 20 years of infertility, and my fertility, I found out recently, has never been worked up or treated properly over the years. And I actually had a botched obstetrical surgery just this summer, where they found out I had endometriosis, and it's never been formally diagnosed despite my requesting orthoscopic surgery to look at it. And I had a fibroid in my uterus that was never found until I started being worked up for IVF, which is very common. About 64% of uterine fibroids are not diagnosed until the patient undergoes fertility treatment. And then the other part of that is I have tissue around my right ovary. They ended up taking out my left fallopian tube, which was blocked. And there were 3 doctors in my operating room, and they looked and they said, there's all this tissue around your right ovary, but nobody could figure out what they wanted to do about it. So they just left it and closed me back up. So the solution still has not been resolved. So my husband and I currently have embryos sitting on ice, which we would hope at some point in some fashion to become our living children, but we're sort of stuck in a stalemate there too. But I had my first miscarriage at 20 or 21.
Okay.
And then I had repeated losses as well.
Now, do you still work as a paramedic or other? Or
No, I transitioned off of 911 during COVID, and I started doing more community paramedic work. Are you familiar with what that is? Kind of like public health nursing. The purpose of that role is to address disparities in healthcare, especially rural healthcare, which we have a lot of that in Minnesota, where I'm from. But then, yeah, in 2022, I transitioned out of work entirely because I just became too sick to continue, which is really sad for me because I absolutely 100% adore my work and I miss patient care like nobody's business. When you're working in a uniform, especially, it becomes so much a part of your identity that if you're not that, it's a huge loss. As she talks to a doctor, right? You know all about how that feels.
Yeah. Now, today, how many different anatomical sites on your body have chronic pain?
Oh goodness. Let's see. Post-concussive migraines, base of my skull, neck, right here. This is the highway of pain all the way down my arm, in here in my shoulders, my mid back this way, a little around my rib cage. And then if I were to stand up, I don't know if you'll be able to see me well, but hips. Oh, I got to come back. And then my left leg is the worst one. When I have a CRPS flare up, it actually feels like someone's taking my hand or my arm or my foot or my leg and actually burning it or trying to rip it off of my body.
Yeah. Are you able to walk without a cane? Or
No, I
walk?
use a cane. I
Pardon?
use a cane when I walk. I use a cane when I walk.
You use
So,
a cane when you walk, okay?
yep.
Right.
If I'm supported properly, I can stand. I have a balancing mat that helps me to stand up, like if I'm in my kitchen at a counter. So I could maybe do a couple things there, but otherwise, I have a cane, my husband helps me, or for longer distances, I have a scooter that I sit on.
Okay, you have a scooter too. Okay. Now, tell us about your current medical program. What are you doing with EDS and your condition? You've got 2 issues. You've got to you got to get some relief today, but you better be on a prevention program to keep you from getting worse tomorrow. So tell us about your therapeutic program for today, and then tell us about your prevention program for tomorrow. Or maybe you've never thought of it that way.
Well, you bring up an interesting point. So I do have some interventions that are in place, but there's also significant gaps and disparities in my care. And like for example, I checked in with my primary care doctor, and kind of about what was going on. And the nurse at the beginning of the visit said, "What's the purpose for this visit?" And I said, "I'm falling through cracks I'm falling through every proverbial crack in the American healthcare system," is what I said. So it took me, goodness, I was actually seeing the same orthopedist for a while, and I was stable on low dose hydrocodone with her for a number of years, about 5 years. And then all of a sudden the practice went completely opioid free, and they pushed everyone towards medical cannabis. And I did try medical cannabis, and I found it to be helpful for some types of pain. Every patient is very different when it comes to that. It's not like the magic potion that they seem to think it's going to be that's going to replace opioids. It's not. It helps for me with some muscle relaxing, certain types of nerve pain, but when it comes to the deep pain in my joints and things like that, it doesn't do anything. And so it took me a couple of years, but I was able to find a pain clinic. But I've had conversations. I've been blunt with my providers that I don't feel like my medication is enough to relieve my pain. And then I always get the pushback from that. I do get some injections. In particular, the one that I get in my SI joint on the left, that one actually, before that, it felt like there was sharp pain always shooting out of my rectum. That one did kind of help that go down a little bit. But at this point, I'm told my spine, my herniated discs are not surgical. And in fact, I think I'm kind of scared to jump on the surgery bandwagon because, once you start doing the spine, it's like a chain reaction. You keep having to do more, right? But other than that, I did have Epstein-Barr virus at 24. I forgot to tell you that. I wanted to make sure I told you I did have Epstein-Barr virus, and I just learned from Dr. Ibsen about that. He directed me to your podcast about that topic. Thank you for doing that. But for example, I asked about ketorolac injections, and because that is part of my migraine cocktail, and my migraine cocktail is Benadryl, Phenergan, Toradol, and Mag. And the extra Mag does calm down the rest of my nervous system when I'm having everything just going haywire.
Say that cocktail again. It sounds very interesting.
It's fluids. And actually, instead of using normal saline, I would recommend all doctors consider and look into using lactated ringers as the fluid instead of normal saline. I find it to be a lot more effective, and it's more buffering systemically, kind of neutralizing that acidosis that goes on when everything's going haywire. But so the fluids, and then I use Benadryl, Toradol or ketorolac, Phenergan, the antiemetic, and then magnesium. So a gram of mag sulfate. And it's the mag sulfate that seems to really calm things down.
Yeah, right. Okay. Now, have you had an Epstein-Barr test recently?
I did. I did have one recently, and that one did come back negative, but that doesn't mean that it hasn't been reactivating at other times. It just means we didn't catch it. That's my understanding. Is that correct?
Well, when you tell me that you have EDS, and as far as long as you do, you probably, if you say it was negative, and this is my worst headache, is that doctors think that when you get what's called the Epstein-Barr test, that you're testing the test that you do for infectious mononucleosis. And that's always negative. And that's what you had.
Okay.
What I'm trying to educate doctors to do is to do the 2 antibodies to the Epstein-Barr, because that tells you whether you've got reactivation and autoantibodies. And the doctors don't know this yet. In fact, we're coming out with our new book here before Christmas on testing and treatment for it. This is and I can tell you that the laboratories that do these tests are tearing their hair out also. It's like trying to educate people that if you got a kid with pain, he's probably got EDS. If you've got longstanding chronic pain, you've probably got Epstein-Barr plus maybe other viral autoantibodies and autoimmunity. And so trying to educate people about this is pretty difficult. But since you asked, I was going to probably do this next show, but the 2 antibodies that you have to have, and I guarantee you yours are going to be positive. One is called the viral capsid antibody, and the other is called the nuclear antigen antibody. And those are the 2 that you got to have. And unfortunately, the doctors don't know what they are or how to interpret them yet. This is new. And there are laboratories that are developing very sophisticated tests about this, and we're going to do our best to try to educate. But I do want even the patients to know that the two antibodies you need are these, because the one that's always negative is the one for infectious mono. You had it years ago, and since you had it years ago, and now you've got all these pain problems. Incidentally, I have yet to see an EDS patient who's middle aged and has pain who does not have Epstein-Barr autoimmunity. I've never seen it.
Okay.
100%. If you know how to do this.
If you do, okay.
Anyway, that's, but anyway, we've got some causes here we're trying to get out. Okay. Yeah, somebody put it up there,
Well-
viral capsule antibody, VCA and EBNA, those two. There's a third and fourth test, but I'm not even going to get into those. That gets complex. Okay.
We had issues. I'm wondering if it wasn't drawn properly when it was ordered, because the lab, I had to go to 2 different labs to get my, what is it, CYP 450. I got those done, but nobody knew how to draw that, how to do that either. And then they're like, this Epstein-Barr thing, what do we do with this? So I'm wondering if maybe the wrong lab work was drawn, despite the order.
Incidentally, if you're taking your ketorolac and your corticosteroid and other things you're taking, you're probably suppressing it pretty well. Okay. You're
Well,
probably doing
actually, that's the other thing I wanted to bring up. So I've been told, so I was initially given oral ketorolac. I was given 5 tablets a month. I was told you can't take it more than 5 times a month because it'll have, renal consequences. And I was taken completely off of that, and they wouldn't even re-prescribe it to me. So I had to find a doctor to even re-prescribe the ketorolac injections. So now I have them to be taken. I believe it's weekly as needed if I need them. But then you're talking about the methylprednisolone, the Medrol dose pack that's really popular. I've actually been told I can't take that anymore. I actually had a really bad reaction when I had what turned out to be a CRPS flare, where my pain was just out of control. It wasn't steroid psychosis. It wasn't at all. I clarified that with the emergency room doctor, but she literally hands me the pack and she goes, I don't want you taking this anymore. It made it worse. And that's when I felt like I was being tortured to death. It felt like I was just being electrocuted to death. And they said that the steroids may have had something to do with that. I was interested to hear what your thoughts were on that.
The steroids would probably calm it down. That's the whole thing. You take the steroids for steroids don't cause those kind of issues. Steroids have complications. Steroids don't cause you to have flare pain or do things like that. Steroids have long-term complications. You're not going to notice anything. And so what happens is that we hear all the time where people want to blame everything on drugs. Okay. Let's take you off your opioids. Let's take you off your ketorolac. Let's take you off your HCG. Let's take you off everything because that must be causing your problem. And that's the sickness in the medical profession. Blame it on the drug rather than on the disease. And my call is look for the disease first and then go from there. Well, thank you very much. Mark, we want to turn not only questioning of this young lady back to you, but we're ready to hear about yesterday's nice program.
Greetings.
Hey, Doc.
So, Katie, I got a couple questions for you. Since you started the injectable ketorolac again, have you noticed an improvement or a difference, or is it too soon?
I think it's a little too soon. I did the first one on Thanksgiving before we went out. I did notice that the one thing I did notice, normally when I go out to an event or an activity, it just takes so much out of me and things get irritated and flared up. I noticed that Black Friday wasn't as bad as I thought Black Friday was going to be. So I can say that. I know that much yet by now.
Good. And I don't have any more questions for you, Katie. Do you have any for me?
Oh, Dr. Tennant did such a wonderful job
Okay.
answering these.
Okay. Thank you.
Thank you so much, Katie. Yeah, Mark.
The session that we had with Dr. Jeffrey Singer and the Cato Institute, it was well attended. It seemed to be I'd like to consider it to be a start. The great thing about being invited is that Dr. Singer did an article called "Cops Practicing Medicine," I think about November of 2022, same month that Dr. Bakoff was taken out by the DEA. And there's a younger version of me in that in that video. I've got brown hair and lots of it. And then he was kind enough to ask me to be part of this session with myself, with Brandy Stokes, who did a phenomenal job of preparing and even creating an opportunity for us to listen to her conversation with Eva Quirion, the nurse practitioner that was forced tapering her. So we got to talk about the unethical aspects of forced tapering. We got to talk about the nationwide myth that Johnny's the high school quarterback. He breaks his collarbone, takes some Percocet, and 7 years later he dies of a heroin overdose. It must have been the Percocet. We got to talk to two influential attorneys, and and so Kate Nicholson had some lovely slides about her efforts for changing state laws. We talked a lot about the interchange between state regulations and national and federal regulations. And then Ron Chapman finished up with legal cases where he's been somewhat successful getting doctors acquitted who've been charged with overprescribing or felony distribution of drugs or whatever that racket is that they have been using against our colleagues. So I think it was considered to be a pretty successful start. I haven't debriefed it yet with Dr. Singer in terms of whether he has any plans to do any follow-up. We had a question and answer session, but our content was probably more than 60 minutes of a 90-minute presentation, and we did. I think what I'm hearing is there's more questions, and could we do more conversational sessions like a town hall that people can really interact with each other? But I thought it was a great start. I got a lot of I tend to speak extemporaneously, and setting up this talk so I could tell my story within 7 minutes. There's a certain amount of power in editing your thoughts, and I've never been good at that. And Dr. Singer really got me editing, re-editing, resubmitting my words, getting the chronology correct. And I think it turned out really great, and I would defer to other people for their input.
Did the group there, do they feel like we're making some headway? And that's number one. Do they think the new administration in Washington will be of a help? What about those two issues?
Well, Ron Chapman is an attorney who defends doctors in federal cases. Then the feds win most of their cases, and so he has won in several federal court dockets with doctors, and we've been used to losing. So I would have to say that that's a shift that perhaps. And the feds don't like to lose in court. I mean, they win 97% of their cases. So once they start losing a couple cases, they will abandon it. And I'm kind of hoping that that's what's happening in terms of the federal court system. As far as Kate Nicholson's presentation, she was instrumental in passing the law in Colorado and the law in Minnesota, which protect patients in palliative care and their doctors. I've had an incident where a patient in Colorado was suddenly dropped from a University of Colorado system when an arrogant pharmacist said he wasn't going to fill her prescription. So these laws have been passed, and she made a great point that passing a law and implementing them are two different things. And so we have a long ways to go.
Can I piggyback off what you're saying there, Dr. Ibsen? On the Minnesota side of things, I would say that my experience as a patient and provider has been very similar. The intractable pain bill, and we currently have a no MME bill as well, passed a couple sessions ago. And I have been trying to educate providers just as I meet them, not even my providers, but in general. and they don't even want to read it. They'll say they're not aware of it. They don't want to read it. Recently, I just had this conversation last week with a pharmacist, and I said, oh, we have an intractable pain bill in Minnesota. I've never heard of it. Oh, here, I have a copy for you. Nope, I don't want it. And yeah, that's actually been happening. And Dr. Tennant was saying, the statistic about how, we've heard doctors saying, 97% of hydrocodone is used in the United States, hasn't heard it in a while. The last time I heard that statistic was actually Easter Sunday of 2019. It was an oncology patient that I brought into a respected level 1 trauma center, big hospital. And this individual had painful radiation burns and was being denied pain control while in the ER. And the statistic he actually said was the United States uses 97% of all opioids, and we need to taper back on those. And in my own practice, and when I treat pain, historically, it's generally on a very short-term basis, but I went from just being given my weight-based dosing guidelines all the way to now, if you were to look in, and I still have all of the apps for every EMS service and every major one in Minnesota on my phone. And now they have actual verbiage. There's actual words that we're supposed to use when we're denying patients medical care. They're actually putting words in medics' mouth to say that that's what we're supposed to say when we're denying pain relief to these patients. And flip backwards from when I started in this field, I worked under, the first medical director I worked under was Dr. Keith Wesley. And he said, doesn't matter. He used to give us pain control report cards to make sure that we were treating our patient's pain when it needed to be treated. Because we are pre-hospital care, we are emergent care. And if this patient comes to us with a need for pain relief, then they're going to get, and if they want it, they're going to get it. That's our job. It doesn't matter whether we think this patient might be an addict or whatever their history might be. It's what's in front of us right now. That was Dr. Wesley's motto. And now he's retired, and now it's completely flipped in my field in Minnesota. So.
Okay, thank you very much. And Mark, thank you for doing this. Again, maybe we're going to keep saying at the closure of every one of these programs, and that is, let's keep going.
Yep.
And I want to close, but a comment just came in from our in-resident philosopher, Donna Wilkes. And Donna asked the question that I want to leave you with. Donna, thanks for this. And that is, why do these people want to stay ignorant? That's not a minor question. I have shocked that the medical establishment doesn't want to face what so many times anymore, it's obvious medical science, much less humanitarian care. I think something's really gone wrong, something that seems to me deep. Why do we want to stay in denial, and why do we not want to progress? And why do we want to stay ignorant? Good question. And anyway, we'll answer that. And Mark, answer that if you got 30 seconds.
Follow the money.
Okay.
Exactly.
All right,
True.
Donna, you got one answer.
Excellent.
With that. Thank you, everybody, for being
Thanks,
here.
everybody.
It's been a great session.
Thank you.
We'll be back next week.
Thank you, Dr. Ibsen.
Again,
God
keep
bless
up.
us,
Thank
everyone.
you so much.
Yes, God
All
bless.
right, we'll
all.
turn it back to you, Jamie, and sign off. Good night.
Right.
Thank you.
Thanks so much, Doc. Go ahead, Dr. Norm.
Yeah, my question is, and I hear this, I heard this from the guests, is that what are the basis? What part of the mesiolimbic system are we not supposed to treat that makes it criminal? I heard today where a guy had a drinking problem. He was an addict, and so we can treat that. And that's all part of the dopamine release system. So what part, again, I always ask, what is the basis for when you deny people, when you're denied, a person denies you adequate pain treatment, and they make this statement, do they also put that statement in writing? And those are the things that questions that I always ask, particularly, when I hear some pharmacists saying, I feel uncomfortable. And I know that what Dr. Ibsen would say. My question is, well, does a pharmacist put it in writing? If you want a corresponding responsibility. All right.
That's great. Thanks
I'll
so
hold my
much, Doc
peace.
Norm. I will see you all next week. Hope you have a great week. Try to stay really warm and try to stay as stress-free as possible.
Oh my goodness.
Thank you,
Very
everyone, for
cool.
having me. You were
Thank you.
wonderful.
All
I
right.
appreciate
Thank
you.
you, Katie.
You were
God bless
absolutely
you. You're
wonderful.
wonderful.
Yes. Thanks for being with us, Katie.
Yeah.
And thank you all for
Thank you,
being with
Katie.
us. Good night and God bless us, everyone. Thank you.
Okay.
Amen. Amen. Thank you. Good
Good night.
night.